No one wants to be a burden, but sometimes all of us need help. Just who do we turn to then? Caregivers caring for us at home. Tonight, On Call with the Prairie Doc.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information. And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. And with the ongoing support of these individuals and institutions. Brookings Health System, Ophthalmology Limited, American Academy of Family Physicians Foundation, and South Dakota Academy of Family Physicians. Avera Heart Hospital, Dakota Allergy and Asthma, CoBank, Fishback Financial Corporation, Vance Thompson Vision, Brown Clinic.
Good evening and welcome to On Call with the Prairie Doc. There is a tendency to think of assisted living facilities and nursing homes for loved ones when they get older, but in truth, it is common for a family member to be the primary caregiver to many elderly or disabled relatives at home and in the assisted living and in the nursing home. First, let's take a look at this week's Prairie Doc quiz question before we get into this. Tonight, give 2 symptoms of caregiver burnout. There are many, but we're looking for just 2 of them, any 2. Viewers who call in the correct answers will be entered into a drawing to win a signed copy of our book, The Picture of Health. Each of my essays, originally written for this show, comes with a wonderful accompanying photograph by Dr. Judith Peterson. We will announce the answer and the winner at the end of the show. Remember, you only have 10 minutes to get your answer in. We answer your questions about caregivers or about any situation associated with caregiving as they are called in or sent to us via Facebook or email. Call in questions to 1-888-376-6225 or send us an email to the address on the screen. Joining us tonight is Dr. Frannie Arneson of the Avera Medical Group Palliative Medicine Care Group, Sioux Falls, South Dakota. Frannie, thank you so much for joining us.
Thank you for having me.
So let's start with an explanation of palliative care. I mean, a lot of people kind of know what hospice is. Many people don't know what palliative care is. Maybe you could compare and contrast.
Sure. So palliative care is a medical subspecialty. It's relatively new. It's only been recognized for over a decade. I think talking about the similarities between that and hospice first makes the most sense.
Okay.
So both fields tend to care a lot about the patient and their family, and not just the medical problems, but whole person care. So they're really concerned about physical well-being and symptom management, how patients are doing psychologically, socially, spiritually, emotionally. They both consist of multiple different specialties within the field, so social workers, nurses, physicians, chaplains, volunteers, pharmacists, to really be able to help the whole patient. Now with hospice care, it is limited by prognosis. So to be eligible for a hospice benefit, generally speaking, you have to be looking at a limited prognosis, generally 6 months or less. However, physicians are allowed to be wrong, so a lot of patients end up kicked off a hospice because they're doing too well.
Yeah.
Whereas with palliative care, there is no prognosis or diagnosis limitations. It's really any patient that has a serious or complicated medical diagnosis and could use an extra layer of support. So we see patients all the time that are continuing to get treatments for their illnesses.
For cancer.
Yeah, like
cancer
chemotherapy, radiation, they
and
might still be on
usually
dialysis.
hospice, they stop all that.
Absolutely. Hospice tends to be more focused on comfort-directed care and kind of avoiding back and forth to the hospital, whereas with palliative, it's really concurrent care, side by side with the other medical teams, trying to provide comfort and making sure that their values are being respected and the medical care aligns with their medical priorities along the way.
So in 1996, there was a study, the support study, SUPPORT, standing for something, but it was in academic centers throughout the country. Mostly med students and residents were being taught there. And they looked at whether people had advance directives. When they had advance directives, were they appropriately respected, the advance directives respected, or the living will respected. They looked at how many went to the intensive care unit, how many had a for sure chance of dying, how much pain they were in. And it was pretty bad.
Really bad.
Yeah, I mean, it showed a lot of pain, 50% of the time, 50% of them were in pain. They also showed that when they had an advance directive, oftentimes it was not respected. Mm-hmm. They also showed that when they had no chance of recovery, they were still put into the intensive care unit, still intubated, still given everything that they could do, dragged through all of these things. And so then they repeated the study with an effort to teach the doctors and to teach the nursing staff and the patients about advanced directive and everything. And after 3 years repeating, they found
Still
no
failed.
difference. It was terrible.
Heartbreaking.
And I think that must have been part of the impetus to do palliative care. Are we doing better now? And is palliative care the reason we're doing better if we are?
I think that we are slowly moving that needle and doing some better. I think that part of it, and I cannot take credit to the palliative care field because there's so many excellent physicians and other disciplines like social workers, nurses, that are really advocating for patient preferences and priorities. I mean, family practice doctors, I think, would be an excellent example of folks that are really advocating for what's important to their patient. So I think that the needle is moving a little bit. I think that we have stressed advanced care planning a lot more over the last decade. And not only are we stressing patients completing those documents, but the most important part is making sure that whoever you appoint to make your medical decisions, to kind of speak on your behalf if you can't.
If you cannot.
Right. To make sure that that person knows what you want. So it's really all about the conversation and making sure that your family and loved ones, especially the ones that you don't put on that form and that might not agree with you, that they're involved in that conversation and understand why your preferences and values are what they are.
Yeah, I love how you put that, because in my mind, if you come to the emergency room and you've got a living will, but your family hasn't bought in, the family can say, do everything, and what do you think the doctor's going to do? They're going to do everything.
That's right.
They're going to follow the family's wishes. So the most important part of an advance directive or a living will is to have the conversation with your family, as you said there.
And choose the person that can put their own emotions aside and truly make the decision that you would make for yourself, as opposed to the decision they feel is right for you, which is harder than it sounds.
Yes. And I think also probably the hardest part is the feeding tube.
It is difficult.
That's the biggest one.
It's difficult.
And unfortunately, I think we put that feeding tube in and then we ask questions later. And I think the real thing, particularly you have the major scenario is a stroke patient, right? They have this big stroke. They come into the emergency room and immediately everybody wants to put a feeding tube in because you can't swallow for yourself, right? Well, really, there's edema in the brain. You need to let the edema reduce. Let's not feed them. Let's not do IV fluids. Let them dehydrate a bit for a couple days. let's live with the patient to see what happens over the next few days. And then you can decide in 3 days, really, okay, is it? And then families come to their senses and go, this is not what my dad would have wanted.
Right, right.
So feeding tube is a tough one.
I agree with you, and not just feeding tubes. I think that making sure that we're having that conversation about what's important to the patient before we do any invasive intervention.
Antibiotics.
Right. Before we do it, let's have a conversation and make sure that the care we're delivering actually aligns with the patient's values.
Now, boy, I love what you were just talking about. Right
stuff.
up my alley. This
Good
is
stuff.
it. This is so important. Did you hear that? Did you hear that? But let's talk about caregivers, because caregivers are our point of attention tonight. Caregivers, there's such a thing as a care provider, which is a doctor or a nurse or a PA or nurse practitioner or whatever it might be. That's a care provider by definition. Caregiver is the person caring for the patient at home oftentimes. Let's talk about caregivers. What's in broad brush about caregivers? I mean, there's many kinds of caregivers.
It's so diverse, right? Because sometimes it's, a child caring for an elderly patient. A lot of times it's a spouse caring for their husband or wife. It might be a grandparent caring for a grandchild. It might be an ex-wife caring for her ex-husband.
I have seen that.
Yes, I have too, many times. And so I don't think that you can put a label on what defines a caregiver in terms of their demographic, but I think that the qualities that they share is that they are investing themselves into the care of that person, and really it tends to be a very personal, and for I think most of them a very fulfilling and gratifying role.
I sense that too, and when it isn't gratifying, it could be, but for some it is not, and you worry about the ones who are sort of stuck, quote unquote, or they have to do it, otherwise we have to go to the nursing home and then we'd lose the farm. Or I have to because my spouse is the child of this person and I am the one that can stay at home and take care of my in-laws, and I have to. I mean, there's some people who are stuck. What's your comment about the stuck people?
Well, I think that in those situations, providing them with the most support from other arenas as possible is really important. So if it's a patient that qualifies for home health services, add that. If it's a family that has some financial means and can afford to pay for some extra caregiving to give that person a break, provide that. If the primary care doctor is asking questions about how they're doing and continuing to give them feedback about what a good job they're doing. Positive feedback, I think, can go a long way for us humans, right? We
huge.
like to feel like we're doing a good job. And so trying to identify the parts of the caregiving that are most difficult for them and that they find the least rewarding, and figuring out if there's a way to offload some of those tasks so that the caregiving can be more rewarding. And then you're right, at the end of the day, sometimes some people just aren't cut out to be a caregiver. And in those situations, we need to think about plan B, C, D, and maybe even E. And help support them in that.
So I often think about good caregiving has to allow that person enough time for her or himself to be able to continue to do it, or else you won't be able to do it. You can't. You have got to be able to have a breathing room. You have got to be able to. I mean, we're talking burnout. What would be the things that would indicate that you sense that there's burnout happening and or recommendations to prevent it?
Well, I think that it's the same signs that we see in healthcare professionals or other professions, that you've become callous. You maybe are feeling anger towards that person. You're finding very little interest in other things that were bringing you pleasure previously. And I think that a lot of times, especially in a doctor's office, if we don't ask, we might not know that it's going on. So I think it is really important that we kind of build into our assessments some questions to the caregiver and how they're doing.
How they're doing.
I always tell my patients and families, it's a marathon, not a sprint. And you have to lean on your village, right? The people that are offering help, say yes and give them very concrete things that they can help you with. If it's that it's difficult to get to the store, ask one of your good friends to pick up toilet paper and bring it to you, or bring a meal, or can you just sit with my husband for 3 hours while I take a nap?
Yeah. You know, a lot of people will come up and say, for various reasons to various people, can I help? What can I do to help? You know, there is, a lot of people resist taking that help.
Right.
But I've been thinking a lot about that lately. We all need help sometime.
Absolutely.
And you know what? When you graciously ask for help, some people gain from being able to give. People love to give.
Of course they
do. I mean,
do.
that makes everybody better. So I think, you know, one encouraging word would be to say, yes, I could use your help. I only needed, you know, a half an hour to get to the grocery store, or exactly that nap.
Right, right.
We've got some questions.
Right.
Do palliative doctors work on pediatric cases?
They sure do. Any age, any stage of
Any
serious,
age, any stage. That's
of any serious medical illness. So there are some palliative medicine physicians that actually subspecialize in pediatric palliative care. Most of us tend to see mainly adults just because there's more adults that tend to have serious illness. But certainly I see my fair share of children as well.
So as a palliative care specialist, did you start as an internist, or did you start as a family physician and then do this fellowship type of a thing? How did that go?
I'm actually a neurologist by training.
That's right, I knew that actually. You told me that
So
the last time you were on the show.
Yeah.
What was that?
A couple years ago, I think.
2 years ago.
A while ago. I was fascinated by the brain, apparently, in my earlier days. And then almost every specialty can subspecialize in palliative medicine, and so that's what I chose to do. It's an extra year of training and specialization, and I practice that 100% now.
That's great. Does a palliative team help caregivers? I mean, and obviously you do. You've already addressed that. How can the caregiver take a break if they are overwhelmed? I mean,
I want to go back to that other question for just a second.
Yeah.
Because I want to point out, in the actual definition of palliative care, it's the only medical subspecialty that includes the patient and family as the unit we give care to. So yes.
Yes.
We absolutely care. And the family is whoever the patient defines as family. It has nothing to do with blood relation.
Right. It may be a spouse, it might be a partner.
Friend. Or it might be a friend. Yep.
How about that caregiver break? How important is that? And how, let's say there's nobody there to give you that help. I mean, how can to me, if you're not getting breaks, you can say, I can't do this anymore and walk away, and that patient then goes to where someone else cares for them.
Right. And this is clearly a very complicated question, and it certainly depends a lot on the financial resources of the patient and family. Certainly, if you have the means, use it to hire yourself a break, to hire some help. If not, there are a lot of programs that, by speaking to your physician, really any of them, they can put you in contact with a social worker that can help align you with resources in the community that can assist with the burden that you're feeling.
So use those resources.
Absolutely. That's what they're there for.
Caregiving comes in many forms and covers all ages, all stages.
So when we talk about caregiving, it comes in a lot of different forms, whether it's children caring for their parents with a mental illness, or parents caring for their children, or a child with special needs, or a spouse caring for another spouse, or an adult child caring for their adult parent. And so we look at, even with all those different scenarios that we're talking about caregiving, when we're caregiving for another person, how are we taking care of ourselves to ensure that we stay healthy throughout that process? What we see is we tend to sacrifice different priorities for ourselves. So whether that's our own medical care, our own dental care, our own self-care hobbies, even things like our own hygiene, we might skip because we are trying to do the best to take care of that person that we're caregiving for. I would definitely encourage people to remember all of the things that they're doing well at, acknowledging that they're doing their best, acknowledging that sometimes we don't have all the answers or all the information when it comes to caring with a child for special needs, or caring for our own children just as parents, or caring for a spouse with a medical diagnosis, or Alzheimer's, dementia, all those components, we don't have all of the information, and so we're doing the best they can. We're all doing the best that we can. And then it's okay to ask for help, and it's okay to give ourselves a little grace when it comes to not having all of the answers, because we're human and we're not perfect. In Brookings, we actually have a Brookings County mental health resource guide, which also touches on some of those different support groups, like the Brookings Empowerment Project, where caregivers are maybe helping care for their older children who have a mental illness, or grief support groups, or different support groups are listed in there. So I always encourage everyone to take a look at what that's listed, but definitely reaching out to your local congregations and asking if they offer any of that is a great option as well. There's also a lot of wonderful support groups that are available for different grief groups, Alzheimer's support groups, autism support groups when it comes to parents. And so really looking at accessing your local supports. Helpline Center and 211 is a great resource when it comes to learning about what's available locally. Looking at all of those natural supports like churches and your family, just kind of being willing to ask for help is okay.
Isn't that nice music? That's our oldest son, Eric, playing the guitar as our music background. I just love it. I'm sorry. This is your program, and your questions are key to the direction of our discussion. Call in your questions to 1-888-376-6225, or send us an email to ask@prairiedoc.org. Please do this. This is your show. Your questions are very important to us. I thought her point about these resources out there that people have, but we aren't always aware of the counselors or the social workers. Let's talk about that a little bit more.
I think that primary care doctors are so important. If you don't have one, you need one. Because I always think of them as the quarterback. They're the ones that have to know tons about everything and recognize when they need help. And so they're so good at triaging, figuring out what other resources are available and how you can best be helped. So your primary care doctor, if you're voicing concerns like that, they can get you in touch with a social worker who then might be able to branch out and find all sorts of different resources. So I always think the best place to start is your primary care doctor, because generally if they don't know the answer, they know how to find it.
And that could be a family physician, an internist.
Yes.
It might be a PA or a nurse practitioner.
Mm-hmm. Yep, absolutely.
So I think we should all have one of those. I mean, if you do and you trust that person, you're a winner there.
It's essential.
So important. So my wife brought this. I want to show you a picture here. Here is a picture of me on a sailboat. And so I'm going to go to the Mayo this coming week, and she's going to put it above my bed. And here's the question: why would anybody want to do that, Frannie?
You absolutely want to do that, and it's because it makes you a person to your medical team instead of just a patient. In the hospital, when we're surrounded by chaos as medical teams and we're really busy and we're trying to do the very best care we possibly can, we sometimes can focus more on the room number and the diagnoses instead of the person. So we sometimes will say, yeah, the gentleman in room 3120 with a history of X, Y, and Z, instead of, yeah, it's a Bill.
Yeah.
And
That sailor.
right, who has kids and a wife, and he was a physician, and this is what he cares about. So it reminds us as medical teams that this is a person in the bed, and you want your doctors and your medical teams to identify with you as that. Because as a physician, I always try to think of, what if this were my mom? How would I want her treated? What if this were my husband? What if this were my child? And you want your doctors and your teams to think of you that way, and them seeing you in your best, healthy, normal life helps them to do that.
And notice, it was cold. I'm not sure there's a little ice on the wall, I'm not sure, but look I've got the long, and I've got a smile on my face.
I was going to say, you might end up with a psychiatry consult.
Yeah.
Sailing
that was
in the
fun.
Dakotas.
She caught me with a pure joy feeling.
It's fantastic.
It's a wonderful, wonderful story. Thank you, dear, for doing that and thinking of this and surprising me yesterday with this picture. And she says, yep, because you're going to show it on that show tonight.
Yes.
And that was it. Does the palliative care team offer social services support?
So we do have social workers embedded in our team that are available to help with the care of patients. And so the things that they tend to do for us is they help assess what the psychosocial needs are. They help to align them with community resources if appropriate. And then most of them have counseling backgrounds too.
Yes.
So they're just fantastic at listening and helping people work through emotional problems.
I love social services.
Oh, they're fantastic.
A viewer from Flandreau asked, please give us an idea of some of the different illnesses that palliative teams work with, or palliative care works with. And I would say some of it is terminal cancer.
Some of it is.
Some of it's just terminal heart disease or terminal lung disease.
It isn't always even terminal.
It's people who are very sick.
Right. So we sometimes will see patients with like a head and neck cancer, for instance, where the treatment is aimed at cure, but the treatment going through it is very difficult, symptom-wise.
It's people who have head and neck cancer. I mean, their tongue is so sore, their mouth is so sore, they can't swallow, nothing tastes good anymore.
Right. The chemo and radiation are really, really difficult, and so is the surgery. So sometimes in those patients, we'll walk alongside them and help with the physical symptoms as well as the emotional burden it takes when you're seeing changes in your appearance, when your appetite is different, when your interactions with your spouse might be different. So we walk alongside, and then at the end of the day, a lot of them are cured and don't need us anymore, and we celebrate in that. We also see a lot of patients with lung disease, heart disease, liver disease, kidney disease, cancers, dementias, strokes, any other neurological diseases. I have a whole clinic where I see our ALS patients. As a neurologist.
Lou Gehrig's disease,
Yes.
amyotrophic lateral sclerosis, where their brain works, they're just losing any control of their muscles. That's a real tragic disease.
And in that clinic, I function as a neurologist, but I use so many of my palliative care skills.
Wow. So it makes me think about several things. I don't want to go there, what I would say is that there's no limit to the reason to call for palliative care. It doesn't mean that we're giving up on our treatment.
Oh, absolutely not. Actually, the reverse. A lot of times, by us helping with symptom management, patients can actually tolerate their treatments better and longer.
It is often the eldest child who is the primary caregiver for patients as they age, for parents as they age. That's right, the eldest child is the caregiver for their parents as they age, and more often than not, that person is a daughter.
It became apparent that she needed help with everyday tasks and driving. We asked her if she'd like to live with us, and it has been 12 years. Before we even talked to my mother, I talked it over with my husband, who was, I should say, he has passed away, but he was a very kind and patient person, and he just didn't see any problem with it at all. And he liked my mother. I had worked in a nursing home at one time, and it prepared me for caregiving. I learned about medication management, bathing, respect for our aging population. You need to take your medications consistently according to your doctor. I use a charting system. I just made up a chart on the computer, the date, time, and the medication. That way, if you adding an over-the-counter, you write it down. That way you know that you can take some more Tylenol after 8 hours or whatever it says on the bottle. And making sure that the medications are compatible with over-the-counter. And this house is newer, so it complies to wheelchair entrance, and my mother is in a wheelchair, so that has helped immensely. A toilet grab bars, my husband put those in, and also we have a shower chair. Making sure you have time of your own. My passion is reading. I love to read, and I have certain times of the day that I take time to read. Work is not a dirty word to me, and I love to be outside and working on lawn or flower beds or whatever the case. It's very rewarding. I don't want to think back someday and say, oh, I wished I'd have done that. But it's not for everybody. So, don't feel guilty if you're not able to handle it. It's, like I say, everybody's different. My mother happens to have a great sense of humor and cognitive function. Unfortunately, she has severe macular degeneration, loss of hearing, and is on oxygen. I feel it's more of a challenge for her than it is for me. She's my best friend, always has been, and she's my mother.
That's a wonderful picture and a wonderful story of a caregiver daughter. I love the fact that she takes some time. She made that point. She's in the garden. She does some reading. That she also made the point, some people aren't built to do that. I also loved the point she made about grab bars in the bathroom. I think all of us should spend some time looking at our own home and make them amenable for people who are disabled, because we could have a person visiting that is disabled. And what else would you take from that, Frannie?
I absolutely agree that her taking time for herself, and you can tell by the way she talked about it, she's intentional about it. So she's not just letting it happen by accident, she's actually scheduling time for herself. Because if we don't, the day slips away, and at the end, we've had nothing to refill our bucket.
Right.
So we have more to give the next day.
Right. And it's interesting, this 91-year-old woman's daughter, the oldest daughter, also is the mother to one of our producers. And so we thank you for doing that for us, Ginger. And thank you so much for bringing Valerie's story to us. Valerie and your mom's story. Those lips. I love that. A Sioux Falls woman says, I've been a caregiver for my mom for many years. How do I encourage another person who is also caregiving to seek additional help? My friend has been trying to take care of his wife by himself. She needs additional care, but the husband is reluctant to help.
That's a hard one.
People need to be able to ask for more help, don't they?
They do, but on the other hand, we have to respect adults' decisions, right?
Yes, we do.
So if he feels that he's managing and is very reluctant to help, just because we think he needs help doesn't mean he does. And sometimes we have to allow him to live through it.
Yes.
And find that for himself. Because oftentimes when adults that can make their own decisions are forced to do something, it doesn't go well.
Right. I think we have to respect people's freedom to choose. That's a principle called autonomy, that we should respect every person's freedom to choose. But maybe that person, like a guy, most guys, are very reluctant to ask for help. Guys should learn. It's okay to ask for help. It doesn't mean you're not the most masculine guy in the world. You could be even more masculine by asking for help. And by the way, when you ask for help, somebody gets back. You know, when they give, they're rewarded
Absolutely.
too. So
I think continuing to show that friend that there is support if he wants to reach out for it, and being present and attentive is great, but forcing it is probably not a good idea.
Good point. We have a caller from Aberdeen who says, who pays for palliative care? Now, I know that hospice is when the physician calls and it's Medicare-aged person, that Medicare covers hospice when it's accepted. So that's an added Medicare benefit. If you qualify or close to qualifying, then isn't that a great thing? Medicare expands, and most insurance people do cover hospice.
Absolutely.
What about palliative care?
Most insurance plans cover palliative care the exact same way that they would cover a cardiology consult or a pulmonary consult, because we're just another medical subspecialty, and we're recognized as that by insurance companies. So most insurance companies are going to cover it the same way they would cover any specialist visit.
Medicare?
Yes.
Medicare
absolutely
covers it.
I mean, the same way it would cover any other specialty visit.
Very good. A viewer from Wall asks about managing medicines while dealing with a serious illness. Who's responsible for this job? Managing medicines.
So our palliative care team oftentimes makes a lot of medication recommendations, and we might prescribe medications. However, it's always in very close communication with the other teams involved. So oftentimes it's not just the primary care doctor, but it's also the oncologist or the cardiologist or the lung specialist. So we're constantly talking and communicating and making sure that all of the medications that we're prescribing align well with their underlying treatments.
Yeah. So I'm going to throw a curveball at you, and this is in alignment with the show that we recorded last week and will be shown in May, and that is the question: do you think that many patients are over-medicated?
I think that is a difficult question. I think that in some situations that is true. When I see a patient that is seriously ill and probably nearing the end of life, I think that oftentimes there are a lot of medications that they've already gotten the maximum amount of benefit that they're ever going to get from that medicine, and at this time is just adding to pill burden, right? So maybe they're swallowing 20 pills in the morning, 13 in the afternoon, and 15 at bedtime. So oftentimes I think it is really helpful to really go through those medication lists with a fine-tooth comb and make sure that everything that they're taking still makes sense and that we're still getting more benefit than potential burden. Now, I think that the opposite is also true for some classes of medications, because I know that studies would show a lot of patients at the end of life still have really distressing physical symptoms. So in those cases, they're on the wrong medicines. There might be some medications that we're not using enough of to provide comfort, depending on what their personal values are.
You gave a case earlier tonight when we were discussing with the pre-professional students, our PDAs, about a case of a man who came in with severe pain and suffering. And you saw him a week later and he was better. Tell me about that.
So this was a gentleman that I saw a couple weeks ago that when he came to my office, he was having severe pain, severe nausea, like writhing in our exam room, moaning,
Retching.
clearly very distressed. And I couldn't even do my entire assessment. He was so uncomfortable. And so we meticulously looked at his medications, listened to him about what symptoms were impacting him the most, and changed some of his medication regimen. A couple weeks later, I saw him today actually, and he rated his pain at a 0 out of 10, his nausea at a 0 out of 10. And so although I can't fix his underlying cancer, we certainly can make an impact on how his daily life can look, and it can be relatively pain-free and relatively nausea-free.
Curveball question again. America's trying to struggle with this question, and you can say, I don't want to answer it, but the question of cannabis. Marijuana is a medicinal plant that's older than the hills and has been used therapeutically for thousands of years. And now, in a time when narcotics and opioids, or opioids, the same thing, are causing a fair amount of deaths, in 70,000 deaths a year, and we're probably not at the pinnacle of that number. What do you think about cannabis as a therapeutic agent? Where should we go in this direction if you were the emperor of the world?
So first I want to comment on the opioid crisis just for a second. I think that every single time we talk about that in our country, it would be my hope that we would say a caveat that this excludes patients with cancer-related pain or terminal illness, because there really truly is a good indication for a certain subset of patients that these medications are life-altering in a good way, and when they're used—
And your patient was an example of that.
When they're used carefully and responsibly, and we're screening patients appropriately and educating them, they are medications that we absolutely need. And so I feel very similarly about medical marijuana. In my profession, I'm always grateful for any additional tools that I have to help patients achieve comfort and symptom relief. So it would be my hope that someday that would be an additional tool that is made available to us.
In South Dakota.
Yeah.
Me too. A woman from Arlington says, during the last couple of years, I've needed help with my husband. It's really hard to find people to help with care in rural South Dakota. I can sometimes get help to get someone to help on Sundays so I can go to church, but that's even a struggle. Does the palliative physician manage this, or the primary physician?
I mean, I'd say the best answer is that we would work together to try to brainstorm ideas and see if there are additional community resources. I absolutely agree with you, though. South Dakota and other places that have very rural areas, it's difficult. It really is. You know, there's areas in our state that don't have home health care, that don't have hospice care even. So I would agree that is a very challenging situation. Since you mentioned that somebody will sometimes come and watch while you're able to go to church, I'd lean on that church community, because sometimes
I would too.
That
Think
church
about
community will help you out on
You
a
know,
Wednesday so you can go get your nails done or your hair done.
You know, maybe standing up at church or talking to the
To your
minister and
pastor.
say, could you bring
need
it
help.
up and say, I need help, I need help. I just need an hour here, an hour there, and an hour there.
And what I've found is in these smaller communities, when you ask for help, there's usually a lot of me. They
Yes.
pull together. They're so community driven and they care so much about one another. You can't be scared to ask for help though when you need it.
Okay. A call, and we've got a few minutes left, and we've got a bunch of questions coming in right now. Thank you very much. A call from Millbank asked, can palliative care take place in places other than the patient's home?
So most of the time, kind of across our country, most palliative care happens in the hospital actually, which is kind of a tragedy because that's way further downstream than we'd like, right? We want to be involved when patients are first diagnosed with serious things, not only when they're in a crisis and end up in the hospital. Right. That is where the most robust services are. And then next would be in clinic. So it's rare to find a community. South Dakota is really included in that, where palliative medicine physicians are available to come to your home.
Okay. A man from Sturgis asked, how do you get through to a sibling that they're doing things wrong with the care of a parent? Is there someone that can help facilitate civil conversations? That's a tough question. There is nothing more important than the love between siblings. And the care that people provide, it can tear apart. I would just ask, a lot of forgiveness needs to be everywhere through this. You know, forgiveness, talk and promise, you know, make a conversation and say, I don't want to have hard feelings. I'm just giving you my feelings, and how can I help other way?
I would say that that is probably the number one or number two indication that we are involved in a patient's care, is when there's discord between family members or there's a lot of conflict, because one of our expertise or skill sets is actually communication and helping to support families through very difficult times and decisions. So
yes.
That would be an indication to ask for a palliative care consultation.
Does the palliative care team help the patient with the spiritual questions that a seriously ill person may have? Spiritual questions, we've got like less than a minute.
Absolutely. Because our spirituality is cornerstone to most of us in our lives. And if we're not well spiritually, or just like emotionally, we're not truly well. And we need that to find peace.
I wanted to spend a half an hour on the spiritual side of things. I didn't get there. Faith Community Nurse, that's an important resource. Think that too. And now for the winner of tonight's Prairie Doc quiz question. Give 2 symptoms of caregiver burnout. Answer could include 2 of the following: withdrawal from family and friends, fatigue, anger, depression, isolation, loss of interest, crying, sleeplessness, oversleeping. And the answers that tonight's winner gave were anxiety and fatigue. It was Angie from Yankton who answered the question correctly. Thank you, Angie, for participating. And a book will be in the mail to you soon. We'll be right back after this.
Have you heard? The Prairie Doc has a radio show. Listen to your local South Dakota radio station for Prairie Doc Conversations. This program features physicians and other health professionals discussing various medical topics important to you and your family. Ask your local radio station if they broadcast Prairie Doc Conversations.
Thank you for listening. Until next time, stay healthy out there, people. It was a number of years ago, and I was working in the emergency room when a severely compromised 20-year-old woman with cerebral palsy came in battling a lung infection. She was moderately mentally handicapped and had muscle spasticity of all her muscles, which hampered her ability to cough and clean out her lungs. This was not her first time with pneumonia, and it wouldn't be her last. What was most remarkable about this young woman, however, was the love and support she had from her entire family, not just mom and dad. Her 3 siblings were also part of this wonderful care team. They joked with her, encouraged her, reassured her, loved her, all of them. It was beautiful to see. The story turned sad as eventually, months later, the patient succumbed to an infection despite aggressive treatment. However, the compassion and joy I saw that day, like rays of light emanating out of her caregivers, left me happy inside. Caregivers come in all shapes and sizes and from all walks of life: male and female, spouse, adult child, parent, grandparent, friend, or hired assistant. They can provide care at home, in assisted living centers, in nursing homes, or in some other institution. They'll be doing this job possibly out of obligation, duty, financial responsibility, love, compassion, or sometimes as a job for pay. Many people develop the need for a caregiver after trauma, illness, stroke, or simply aging, while others require help from birth. The needs of the compromised individual can also vary. Sometimes they require lots of help with activities of daily living, including bowel and bladder care, or even help with feeding and hydrating. Sometimes the person only needs someone to check in on them every day or give them a kind word every once in a while. After my dad died, I found myself calling my mom every morning while I was on the way to work for a short call. After several years of this, when a stroke took this pleasure away, I came to realize how much I grew from and enjoyed those daily conversations. It had been a mutual gift we were giving each other. The following lessons for caregivers might be helpful. 1, practice listening. 2, be kind, honest, and respect your patient's choices as much as possible. 3, seek alternatives if you're feeling burned out. And 4, realize the value you receive by the giving of yourself. A big thank you to Frannie Arneson for volunteering to come to our studio at Yeager Hall on the campus of South Dakota State University. The experience in the field of caregiving was key to tonight's program. My new book, Life's Final Season, addresses the needs of caregivers and is available at the locations you see on your screen right now, and it is also on loan at public libraries in Brookings and Vermilion. Ask your local library about it. Our media world here at the Prairie Doc is more than our program each week. You can hear us on many radio stations around South Dakota with our Prairie Doc Conversations. Prairie Doc Radio is on KBRK here in Brookings each Wednesday. Over 59 newspapers print the Prairie Doc Perspectives each week. And for those of you traveling outside of South Dakota, you can watch the program live on Facebook, 7 o'clock Central Time on Thursdays. While you call or text your questions just the same as when you are watching us on South Dakota Public Broadcasting. Like our Facebook page and go there each week and join the conversations. The South Dakota Department of Health has already gotten several confirmed cases of the flu, and the season is just beginning. It really isn't too early to get your flu shot. It's important not just for you, but to help protect those around you. Well, that does it for tonight. From all of us here at On Call with the Prairie Doc, until next time, stay healthy out there, people.
A can of pop, a single chocolate candy, and even a slice of bread can cause problems. Diabetes, not a sweet condition. Next time, On Call with the Prairie Doc.
All of us want our family, neighbors, and friends to have the ability to make appropriate decisions about their health care. To do so, they need access to information from reliable sources like Dr. Holm and his guest physicians. Hello, I'm Stephanie Herseth-Sandlin, and I serve on the volunteer board of directors of the Healing Words Foundation, a 501c3 organization established to support the work of the Prairie Docs. With your charitable donation, you can help the foundation continue to offer free and easy access to the entire library of Prairie Doc health education programs. This mission is so very important to rural communities and residents in particular across South Dakota and neighboring states. Please consider a personal or corporate gift. Just go to prairiedoc.org to find more information on how you can help. Thank you.